Thank you for that introduction, and thank you to Town Hall Seattle for having us here. It's an honor to share our research with the community. I want to share my research in treating traumatic injuries and the truth about trauma research and how a new therapy developed in my research group in the Pun Lab can potentially save lives. So I want to start by outlining with a little bit of background what traumatic injury research looks like, and also what the funding situation for moving traumatic injury research forward looks like. And to do that, I want to start by showing you this graph, which outlines that the number one cause of death in Americans under the age of 46 is traumatic injury. And this accounts for about 4 times more than either of the other leading causes of death, those being cancer or heart disease. And it can be very easy to forget how fragile we all are. Of course, it's not fun to spend all of our time thinking about that, but the threat of traumatic injury looms around us all of the time. When you start to think about things like vehicle accidents, falls, violent crimes, workplace accidents, and a local favorite, the Boeing 737 MAX. I'm thinking about this chart every time I fly now. But you start to see how this fits into the larger picture. And quite interestingly, you see when you look at this graph showing the amount of funding that our government is giving to developing treatments for different kinds of disease states, you see that traumatic injury research is absolutely dwarfed by things like cancer and infectious disease. And so, considering that, maybe it's not so surprising that when we invest so much less resources in traumatic injury research that we see it taking such a significant toll on our health as a society. And so I now want to talk about what our current approaches for treating traumatic injuries are, what are our doctors doing in clinics today, and why is it maybe not quite enough. And so to do that, I want to first define the kind of traumatic injury that I'm going to be talking about, and that is severe blood loss, which is also known as hemorrhagic shock. So when a patient sustains a traumatic injury, it's not uncommon for them to lose up to 60% of their total blood volume. And when that happens, a lot of bad outcomes result. You see that without all of that blood in your vasculature, your blood pressure really crashes, and that means that without that pressure, your body is unable to deliver blood to all the nooks and crannies of your body, and when the blood can't get there, that means oxygen isn't making it to those tissues either, and you see that death can occur within a range of minutes to hours. And just to outline some of the societal impact of hemorrhagic shock, you see that 35% of all deaths that occur in patients before they're actually able to reach the hospital occur due to hemorrhagic shock, and that accounts for about 1.5 million deaths annually. And so, how do we treat hemorrhagic shock? How do we treat blood loss? It makes sense that when you lose all of this fluid in your body, you need to replace it with some other kind of fluid, and those are called resuscitation fluids. There are a few that we'll be talking about today. The first and best one is whole blood. That's blood that might be collected at a blood drive. It has everything that blood should have, and it's the gold standard. But unfortunately, blood isn't always available, especially in the pre-hospital setting. It has really complicated storage requirements that need really fancy refrigerators that can't be taking up all the room in the ambulance. And so our EMTs and our paramedics have to turn to different synthetic alternatives, non-natural alternatives. And so what ends up getting used most commonly is just saline, a solution of salt and water. And that should concern you. When you're trying to replace something that took millions and millions of years of evolution to create, that being blood, you're trying to replace it with table salt and water. And it works about as well as you might expect. And so I want to spend a little bit more time talking about the pros and cons of each of these resuscitation fluids, whole blood and saline. So the pros of blood being that it's what's supposed to be there in the first place. So it can be replaced at a 1-to-1 ratio, meaning that for every 1 liter of blood that a patient loses, you only need to replace that with another liter of blood. And because it's what belongs there, you don't see any adverse issues with coagulation or blood clotting. It's really important that when you're treating these patients, you don't take away their ability to form blood clots, because these are trauma victims, and they really need to be able to form those blood clots to stabilize their condition and survive to the hospital. And so some of the cons, I mentioned that blood products are really not available, and so this makes them impractical for use in the pre-hospital setting. I want to outline that in low and middle income countries where 90% of traumatic injuries worldwide are occurring, it can regularly take as long as 6 hours to transport a patient to the nearest trauma center. So solutions that are focused towards this pre-hospital setting are really important. And because blood supply is dependent on different donations in the area and also blood typing, things get really complicated. And this is what forces us to turn to those synthetic alternatives like saline. So saline is good at a couple things. It's good at being cheap, it's good at being easy to make, and it's good at being around. And you don't need to blood type either, which is another great advantage. But so the cons being, I mentioned, maybe it seems obvious that blood can be replaced at a 1-to-1 ratio. Saline can only replace blood at a 3-to-1 ratio. So that means that if a patient loses 1 liter of blood, they need 3 liters of saline to recover their blood pressure. And pumping your patient full of these large volumes of salt water has a lot of adverse effects. It can literally cause them to swell up. It can make their blood pressure reach dangerous heights. And it also can affect the ability of these patients to form blood clots, which is among the most life-threatening thing that you can do to these patients. So both of these are far from being a perfect treatment. You see that even though it's not accessible or practical, blood is great, and we can draw inspiration from the fact that you only need a 1-to-1 ratio of the blood. It can stably recover the blood pressure, and it's safe for coagulation. And while saline is accessible and practical, it suffers in these other areas. So when you look at this, you see that this area of medicine is rather stagnant. We, for some reason, decided that we were fine with saline. We didn't want to contribute any more money to developing the cause. And so this is what we've been doing since the 1960s. And so my research in the Pun Lab is trying to develop a more suitable therapy for this era of modern medicine. And I just want to remind everyone that the reason that it's like this is that funding situation. So can we make a therapy that can check all of these boxes? And now I want to talk about what we have developed and proposed as a solution. And so let's do that. So there are 3 elements that I want to focus on for what a perfect treatment would look like. The first being volume. If you can accomplish the same thing with less medicine, that is always going to be excellent for cost and pretty much every reason. So when you're minimizing this, it makes things easier to store, makes things cheaper, and we're also interested in developing a therapy that can stably recover the blood pressure. That's something that can't really be achieved with saline because you're infusing such large volumes all at once and spiking the blood pressure. So you need something that can calmly restore the blood pressure. And lastly, you need something that isn't going to take away the ability of those patients to form blood clots. So our mission is to develop a therapy that does not require a large volume to replace that lost blood, to develop a therapy that can replace that blood pressure slowly and avoid blood pressure spikes, and to develop a therapy that does not prevent the patient's ability to coagulate. And all 3 of these aims were able to be achieved by our therapy, which I'm going to be talking about now, and that is called a low-volume resuscitant treatment, aptly named. So what that means is you only need a tiny, tiny bit to replace all of the blood that is lost. So to outline how this works, I'm going to call up a friend into my slides. His name is Derek. Don't get too attached to Derek. remember the context of what we're talking about here today. So unfortunately, Derek was involved in a tragic ski accident and lost about 60% of his blood. And so there are a few different approaches we can take to treating Derek. All of them involve giving him some kind of blood replacement. So just to get things in proportional scope, let's say that Derek lost 10 droplets of blood. Derek has 10 droplets of blood, 60% of those droplets were lost. And if you were going to be using whole blood to replace this, it's a 1-to-1 ratio. If you're going to use saline, you need this much fluid to recover the blood pressure. And if you were to use the therapy that we've developed in my research, you only need 1 droplet of that blood. And so this is very advantageous for a number of reasons. It makes things very portable, and it makes things usable in the pre-hospital setting. And so an LVR can replace about 6 times its lost volume of blood. And I'm sure you're wondering how that is possible. And so I want to talk a little bit about how these LVRs work. They work through something called colloid pressure. And so a colloid is something that exerts a force on the fluid around it. And so when you see on the right side here, when you have more of those colloids represented by the stars, these pull fluid towards themselves. And you end up, over time, seeing a flow of water from the left, where there are less colloids or less LVRs, towards the right, where there are more colloids or LVRs. And you see that the fluid will follow. And, So now I want to talk about how this works in the context of the human body. So after the traumatic injury occurs, that blood that is supposed to be in your bloodstream has escaped into your muscle tissues and your fat tissues. And following this, when you're able to infuse this colloid, this LVR, you're now introducing that colloid pressure into your bloodstream. And so in the same way that fluid will follow in the diagram shown from less colloids to more colloids, you'll be able to recover that blood by creating a pressure gradient and pulling it back into the vasculature. And this is how we get Derek back onto the slopes. So LVRs are injectable into the bloodstream. They're able to develop these pressure gradients, and in doing so, they're able to pull all of the fluid that was lost back into the bloodstream, recover that blood pressure, and stabilize your patient. And so with our mission having been to design a treatment that can accomplish things at a low volume, can recover things stably, and to prevent the ability to form blood clots, you see that when we look at our key outcomes, starting with the volume, that you only need about 2 mils to replace 14 mils of blood lost in our rat experiments. So a rat has about 20 milliliters of blood, and when they lose 14, you only need 2 milliliters of LVR treatment to replace that blood. And when you look at how this blood pressure can be infused and restored slowly, I want to point your attention to the blue curve. You see that it is able to really slowly climb up over about 10 minutes and reach the desired pressure window, which is shown shaded in gray. So that allows us to determine that we were able to stably recover the blood pressure. And when we are looking at the ability of this therapy to perform its function without impairing the ability of the patient to coagulate, we see this data, which I don't want to get into too much, but the blue is our LVR polymer. It stays within the range of the purple. Right next to 0 does not affect the rate of clot formation or the strength of those blood clots. And so now I want to talk about how LVRs can solve the problems that I've spent the initial part of this presentation outlining. So with traumatic injury leading the cause of death in Americans under the age of 46, you see we're not receiving the resources that we need to really push this therapy forward. And with all of these flaws in the 2 solutions that are available to us right now, there's really an urgent need for the development of a replacement alternative therapy. And our LVR demonstrates the ability to fill that role. And much more work will be needed. And just for fun, I kept most of the chemistry out of this presentation, but this is a crude artistic rendering of what this polymer will actually look like. It's kind of like a little star with its arms branching out in different directions. And I want to acknowledge my research team in the Pun Lab at the University of Washington, as well as our collaborators in the Department of Emergency Medicine, which help us perform these animal studies. Thank you guys very much for your time.